Okay. So the next talk is going to be by my colleague and friend, Jay Morris, member of our radiology, neuroradiology department at Mayo Clinic in Rochester. And his passion is for 3D printing and football, or what you call here soccer. But he's a great radiologist, and he's going to talk to us about neuroradiological pearls for the Neuro ICU.
So I talk a little fast. There's going to be a lot of pictures. I'm a neuroradiologist, like Dr. Rabenstein said, and we're privileged that, one, that they allowed me to come here and talk, and then two, that we're able to work with all the neurointensivists throughout Mayo Clinic, because it really is a team. So stroke is very common. It's even common where we live. We only have 110,000 people in our town, but we service about 3 million people from about 40 countries coming there. And even in our small community, there's quite a bit of stroke going on. And we really need some imaging timestamps, either to substitute for a witness or identify salvable tissue, because the goal is to triage as many people as we can IV TPA, either through the telestroke program, in-house, and get people that have large vessel occlusions to embolectomy. So we do the non-contrast CT in everybody. So there are some neuroimaging surrogates for time or tissue at risk, and there's a few things you can get from the non-contrast CT, mostly contraindications, but you can get aspect scores. You can get the CT perfusion after the non-contrast study, and we did a lot of this a decade ago, and then we stopped doing it for a little while, and now we're all back in with some more complicated math that we'll get into. So because now there are these threshold values and core infarct volumes that we have to measure. There are people that do DWI flare mismatch. We don't do it in our institution, mostly because we don't have an MRI available 24/7 to just do stroke, and we don't like taking people out of the magnets to put a patient in there. But there are people that do dedicated MRI, and if you have a flare DWI mismatch, it's likely less than about 3 hours. So in 2015, one thing changed for a mechanical embolectomy, in that it was shown to be more efficacious in multiple studies, not just for recanalization, but also for improved modified Rankin scores in almost every trial that studied this. And although they used similar devices in a lot of these trials, it was proven that we should be getting to mechanical embolectomy faster. And then more recently, 2 trials came out that said not only should we get there faster, but now we can do it between 6 and 24 hours. And that's really where perfusion comes back, because under 6 hours, large vessel occlusion, if you're playing around waiting for the perfusion at our institution to get post-processed, they're already punctioning the groin. So, I mean, this is really for the 6 to 24 hour period, or when we're dealing